Hello and welcome to my video lecture on the topic of Neuraxial ultrasound. In the talk, I will focus specifically on how to do a brief procedure ultrasound scan before spinal epidural placement. The talk will be divided into four parts. The first one will talk about the benefit of using ultrasound. The second and the third part will talk about the technical aspect. The second part will talk about the parasagittal plane. The third part will talk about transverse plane. And the last part we'll talk about barrier and limitation. Part one, benefit of ultrasound. One thing I find fascinating about spinal epidural, it is not a lot of changes in the way we do things when it comes to spinal epidural. If you talk about airway management, we have video laryngoscope that make intubation a lot safer. When we talk about peripheral nerve block, we have ultrasound that make the procedure a lot safer as well. But when it comes to spinal epidural, we still performing it the same way we've been doing for decades. There's not a lot of changes, but we are pretty good at it. We are successful most of the time, and some of you that do a lot of OB can be very proficient at it. So you may ask, why make something that already working pretty well more complicated? And the answer is, even though we are pretty good at what we do, once in a while we run into this situation, and I think all of you can relate to this situation. Patient with severe scoliosis, obese patient with previous back surgery, and now things get a lot more complicated. And what even more interesting is, when we struggle in this situation, we oftentimes repeat the same technique. When it comes to airway management, if we struggle, we switch to video laryngoscope or we go to fiber optic intubation. But with spinal epidural, we oftentimes just repeat the same sequence. We may try to redirect the needle. We ask ourselves where we are. We redirect the needle, and after a while, we may go to a different space. But we essentially repeat the same technique. So in some way, we don't really know where we are, and I think this is where the ultrasound gonna come very handy, and it's gonna be a very valuable tool. So if you're curious by now, you may ask, what is ultrasound going to do for me? And the short answer is it helps you plan better. Before you stick a needle into the patient back, you can get so much information that you would not know otherwise, or some information that you technically can get from the landmark technique, but it's a lot harder. So the color code in red here is that information that you would not get without ultrasound. With ultrasound, can predict how many centimeter to the ligamentum flavum. You can predict the needle of the angle of your needle. Some of you can relate. You try, no matter where you direct your needle, you keep hitting us. So ultrasound can help you predict the angle of your needle. The one in yellow, theoretically, can ask the patient, use your physical assessment, review the patient chart to figure out if they have scoliosis and metal from previous back surgery, but ultrasound just make it a lot more reliable. And lastly, the information you can get from palpation. But one thing I want to point out is about the identification of the level. We are actually not as good as we think we are. We often go higher than we should. And then also the L5S1 interspade is pretty large spade and actually pretty good for spinal epidural, but it can be difficult to palpate. So if you don't not able to palpate it with the traditional technique, you may skip these valuable spade. And lastly, identify midline, which sounds like a very simple task, but I'm sure in some patient that you encounter, it's simple, but it's not easy. So what does all these information translate to? It's hard to prove that like ultrasound improves safety because injury to the spinal cord is pretty rare to begin with. But there's some evidence showing that ultrasound reduces the technical difficulty. It helps reduce the number of needle puncture, needle passes, and it also showed to improve the clinical efficacy. It lowered the rate of incomplete labor analgesia and epidural failure.